I'm Dr. George Simon. I'm a professor of medicine at the H. Lee Moffitt Cancer Center in Tampa, Florida. Working with the ONC-AI team, what we wanted to do was actually come up with a marker that is a better predictor than PD-L1 IHC. PD-L1 IHC is the most commonly used marker to select immunotherapy in patients with advanced stage non-small cell lung cancer, whether we should use immunotherapy by itself or whether we should use immunotherapy plus chemotherapy. PD-L1 is the most commonly used marker, but the problem is it's an imperfect marker. We wanted to come up with a better predictor of benefit to IO therapy. So what we did was we developed a artificial intelligence-based model where we use radiomics data, we'll use demographic data, and some laboratory data, and integrate all of this data, ingest and analyze all of this data, and train an artificial intelligence system. So we have, to date, inputted about 800 patients, 791 patients, and have about 2/3 of those we are used to train the system, and then we are trying to validate the system in about 250 patients. So far, we have been able to show that we are a better predictor of immunotherapy benefit compared to PD-L1 IHC. This model continues to evolve and we are going to increase the input. But if you look at this graph here, what we show here is that we use demographic data, laboratory data, and radiomic data. These are all image verified, annotated, put into an algorithmic calculation system, and then it is analyzed and a report is delivered to the medical oncologist. So using this system, what we have shown here is that our multimodal multimodal analysis system is a better predictor at 0.83 ROC AUC compared to PD-L1 IHC at 0.64. And this difference was statistically significant for first-line IO monotherapy in advanced stage non-small cell lung cancer patients. But we also wanted to see what our predictive capacity was in patients in individual PD-L1 subsets. So broadly speaking, PD-L1 is broken up into 3 categories: less than 1%, 1 to 49%, and more than 50%. If you break it down by PD-L1 characteristics, within each PD-L1 subset, our system was able to show a statistically significant predictive capacity with a hazard ratio of, with a ROC AUC of 0.71 and a p-value of 0.005 in each of those categories. This is the more than 50% subset. This is the 1 to 49% subset where we had a p-value of 0.003. So now when we throw in chemotherapy with the immunotherapy, our predictive capacity predictably reduces. And if we were to apply the same algorithm for just chemotherapy alone, we completely lose any predictive capacity, suggesting that it is truly a predictive model to the use of immuno-oncologic agents. So we are hoping to improve on this. Currently we have a ROC AUC of 0.83. By putting in few more thousands of patients, we hope to get into the low 0.9 predictive ability to further improve our predictive capability over time. Now, one of the key advantages of the system is we don't need any additional testing. We use the data that are already available in the chart, and we extract that data and come up with this model. So we don't have to send off any more tissue or any more blood for any additional testing. We use the existing information and try to optimize that information to come up with a better predictive model to IO benefit compared to just PD-L1 IHC. So hopefully this will eventually be a better biomarker, if you will, for predicting IO benefit in patients with advanced metastatic non-small cell lung cancer.